participants today. Actually, Dr. Tim Dribin is a pediatric emergency medicine physician and an associate professor at Cincinnati Children's Hospital. He's internationally recognized for his research on anaphylaxis, contributing to clinical guidelines and publications in leading medical journals, including The Lancet, Child and Adolescent Health. So, Dr. Dribin, the floor is yours. If you have any presentation to be shared or a discussion to be started.
Well, thank you very much for having me. Yeah, I didn't create a presentation. I was more hoping, if you had questions about the article and stuff, I'd be happy to talk about that. I mean, I can give you just a general kind of overview of, why we did this study and kind of my kind of interpretation of it and everything like that, if you'd like, and then would love to be able to answer any questions that you have about that. So one of the big, I am a pediatric emergency medicine in Cincinnati Children's Hospital, and I have spent most of my career studying anaphylaxis and really trying to figure out how we can best optimize the care of children, but also adults with anaphylaxis, both in the healthcare setting, but also before patients, arrive in the emergency department, given that a lot of anaphylactic reactions, especially from food exposures and kids and adults happen, outside of the hospital setting, where people are exposed to stuff, and then they have to decide whether to administer epinephrine and then decide whether to come to the emergency department. And then when patients are in the emergency department, when I started my training, one of the, you're always told kind of how to recognize anaphylaxis and then how to what to do with these kids. And when I started practice, we actually were admitting almost every child with anaphylaxis who got epinephrine to the hospital, and that was because of this risk of biphasic reactions. And at the time, there was a wide variation of the reported incidence of biphasic reactions, anywhere from like 5% to 21%. Despite, I think, most clinicians saying that it's pretty uncommon for them to have actually seen a biphasic reaction. But the fear was, if you have anaphylaxis, you need to be hospitalized to monitor for these reactions. And the other challenging thing about biphasic reactions was that they were reported to, occur up to 72 hours later, which is a really long time. And obviously, we do not want to admit children for 3 days to potentially monitor for this biphasic reaction. And the more work we did was that a lot of this reported differences in the incidence of biphasic anaphylaxis was because people were using different definitions of how to define biphasic reaction, where some clinicians would say, if you have anaphylaxis and then let's say their symptoms go away, or maybe they still have some, isolated urticaria and then they vomit one time, that's biphasic reaction. Whereas other people would say if their symptoms completely go away and they have some recurrent angioedema or hives, that's biphasic reactions. And then there's others who would say, hey, when their symptoms go away, their recurrent symptoms have to fulfill anaphylaxis criteria. So it can't just be any recurrent symptoms. It has to be symptoms that are severe enough. So a lot of the, I think the main reason that there are these variations in the reported of how common biphasic anaphylaxis is because there's inconsistent terminology used to define these reactions. And our group in, I think, 2020, we published a consensus report in Journal of Allergy and Clinical Immunology where we standardized, how to define biphasic anaphylaxis. And I do think it's important for clinicians just that you can have biphasic anaphylaxis and then you can have biphasic non-anaphylaxis. And the difference really is whether, first of all, all symptoms have to completely resolve from the initial reaction, and then there has to be some time period where they're asymptomatic, and that's at least 1 hour up to 48 hours, and then their recurrent or their new symptoms have to also fulfill anaphylaxis criteria. I think that's helpful when we speak as clinicians to say, was this a biphasic anaphylaxis? And then let's say their recurrent or their new symptoms don't fulfill anaphylaxis criteria. They just have recurrent angioedema or some hives that come back. That would be biphasic non-anaphylaxis. I think that's really helpful to standardize how we speak clinically, but also for research purposes that we're all trying to assess the same outcomes in clinical research. So the true probably incidence of biphasic reaction in our study in the Lancet Child and Adolescent Health is much lower than 21%. It's probably lower than 5% there as well. So the question then was always, if these reactions are occurring 21% of the time, how long do we need to observe patients either in the emergency department or in the hospital setting to make sure that they're not, that they're at low risk of needing a subsequent, dose of epinephrine, and they could potentially, go home. With the hope that, hey, we could potentially reduce how long people are being observed, and then we could potentially also reduce hospitalizations, which, hospitalizations can be burdensome for families and the healthcare system. So that was the big hope, was that we could try to stratify how long patients need to be observed. And the other thing is that prior recommendations about how long patients should be observed, it was very clear that there's really insufficient data to inform that it was mainly expert recommendations that people would say, up to 4 to 8 hours, and then some of the British recommendations were even longer. So there was a lot of inconsistency and insufficient data to inform practice recommendations. So there was a need to try to answer this question. And then the other thing that our group sought to do with this study was that instead of looking at anaphylaxis like the reactions are all the same severity, which we all know in clinical practice that, like asthma or anything that we treat, right, there's a lot of variation in severity. You could have someone with anaphylaxis who has, skin mucosal involvement and gastrointestinal involvement, and then conversely, you could have someone who has, respiratory failure or shock, is much different. That the observation periods probably should reflect how sick they were. That we had the hypothesis that if you're sicker, if you have more significant organ system involvement, that you probably need to be observed for a longer period of time than those patients who are less sick. So just trying to tailor our management to reflect their disease phenotype, which is, I would say, how we care for most conditions in the emergency department, whether it's asthma, bronchiolitis, the less sick you are, you may not need to be observed as long or observed at all, versus the patients who are sicker, need to be observed longer or potentially hospitalized. So to assess this question, we conducted a 31 center retrospective cohort study. This was conducted in 30 centers in the US and then one Canadian center, and it was conducted through the PEMCRC, which is a research collaborative through the American Academy of Pediatrics. It's a voluntary research network where people at all the sites just volunteer to do chart reviews. Typically, it's retrospective. There's no funding for this, which is impressive that people just enjoy research and want to collaborate. So we conducted this study across these centers, and for inclusion, patients had to be 6 months to less than 18 years of age, and we looked for anaphylaxis ICD-10 codes to first identify those patients, and then for inclusion, the patients had to receive at least one dose of epinephrine, either in the pre-hospital setting or in the hospital setting. So if let's say they had anaphylaxis in the pre-hospital setting or in the emergency department, they never received epinephrine, they were not included, because we wanted to base our observation times based on that timing of when they received their first dose of epinephrine. So it's always important, I think, when you look at inclusion-exclusion criteria, that if patients, we didn't include patients who didn't receive epinephrine, then you should not apply these findings to patients who never received epinephrine. So I think that's very important to state. Of note, patients did not have to fulfill the 2006 National Institute of Allergy and Infectious Disease food allergy and anaphylaxis network criteria for anaphylaxis. So those are called the 2006 NIAID-FAN criteria, which are what are commonly used in research to figure out did someone likely have anaphylaxis. For this study, a patient could be included if they had an acute allergic reaction and they received epinephrine, even if that reaction didn't fulfill anaphylaxis criteria. And the reason being that if you receive epinephrine, it could potentially mitigate how sick you are. And because of that, it could prevent reaction progression. So, and that we thought was important because we see a lot of patients who get epinephrine by their families or maybe by the pre-hospital providers, paramedics, and they never fully had anaphylaxis. And then we're left with, hey, how long do we need to observe this patient? So we wanted to be able to apply that as well. And then our primary outcome to inform how long to watch patients, because this was a retrospective study, we couldn't, figure out exactly in the charts, it's not well documented in the medical record how long symptoms lasted. So we couldn't get at symptom, or physical exam finding duration. We used how long patients or when the timing was of their last epinephrine dose. So we had the timing of their first dose, which was time 0, and then we had when was the time of their last epinephrine dose. For patients who were, the sicker patients in the cohort, those, on vasopressors, epinephrine infusions, we based that on the time when their epinephrine infusion was discontinued. So when that was stopped. And obviously there are not many patients who are in that category. So what we sought to do was to try to find what an optimal observation period was, which was we a priori said when there was a less than 2% increase in the cumulative risk of receiving an additional dose of epinephrine as the observation period was extended by 1 hour. And then we also looked at different observation thresholds, so a less than 1% increased risk. And then in the figures in the manuscript that you'll see, as the Kaplan-Meier curves, the time to event curves are shown, you're able to look at after every hour after that initial dose of epinephrine, and you can see how many patients receive epinephrine after that period. So we'll get to that in the conclusions, kind of, but the point of this being that patients and clinicians have different risk thresholds, and some clinicians are, very comfortable with patients going home and potentially maybe need another dose of epinephrine where they would tolerate a shorter observation period. But a shorter observation period means that your risk of needing additional doses of epinephrine, would be higher than if you observe someone for a longer period of time. So we provide that data as well to inform care. And then what we did is, so our primary outcome was that time of the last dose of epinephrine, and we sought to figure out when there was that less than 2% risk of needing an additional dose of epinephrine. And then we stratified the cohort. So we first looked at all patients in the cohort. There were 5,600 and I think 41 patients. And then we also stratified it based on their initial reaction symptoms. So it was either all patients in the cohort, then we looked at patients who had no respiratory, no cardiovascular involvement. So those would be people who had skin and mucosal involvement or gastrointestinal involvement. Then we looked at patients who had respiratory involvement, plus or minus a skin mucosal, but did not have cardiovascular involvement, and then patients who had cardiovascular involvement. Just trying to kind of risk stratify based on those different severities, recognizing that in anaphylaxis as a whole, but especially pediatric anaphylaxis, that cardiovascular involvement is less common. Cardiovascular involvement is a little hard to define in kids, especially like the younger age group, but we defined it as, obviously hypotension, but syncope, and then, if the patient felt dizzy, or passed out, those would be classified. So, and then in our sub-analyses in the supplemental materials, we looked at patients who were hypotensive, and there's just not many patients who are hypotensive. And then to the main findings of the study, which you can, if you have the paper in front of you, it's figure, let me see here. It is the main figure where they had the different Kaplan-Meier curves that you can see. So the Kaplan-Meier curves show time 0 is when patients receive their first dose of epinephrine, and then every hour up to 12 hours is shown there. And as you can see, the Kaplan-Meier curves start to become flat pretty quickly, which means that there's very little benefit of extended observation at that period. So for patients in the entire cohort, the 5,641 patients, the optimal observation period for the less than 2% risk was 115 115 minutes. And for that, there were 5% of patients who received epinephrine after that time period. And then when you look at patients who had no respiratory, no cardiovascular involvement, so that was 1,070 patients, that 2% threshold was 105 minutes. So that's showing that, if you're less sick, 105 minutes was probably fine. And then for patients with respiratory but no cardiovascular involvement, which was most of the cohort, 4,076 patients, the less than 2% threshold was 119 minutes. So not that different, really, 105 versus 119 for sort of respiratory. And then for those with cardiovascular, it was only 495 patients. The 2% threshold was 161 minutes. So again, a little longer period. So if you have cardiovascular involvement, it's a little longer. We then, it's also helpful though to look in the supplemental table. The journal had we did a ton of sub-analyses where we looked at different degrees of organ system involvement. So we looked at not just cardiovascular involvement, but patients who had more severe cardiovascular involvement. And then we also looked at patients with not just respiratory involvement, but patients with more severe respiratory involvement. So patients with more severe respiratory involvement, so those patients who had like respiratory distress, stridor, there were 3,008 patients who had more severe respiratory involvement. And for those patients, the optimal observation period, if you look at that less than 2% threshold, was around 164 minutes. And then the risk really for these patients, if you have more severe respiratory involvement, their risk really beyond 4 hours, their risk of needing repeat epinephrine is around 2.3%. So I try to, make sure that, even within respiratory involvement, that if you have the more severe involvement, if you have someone who comes in and they look like they're really, having a lot of trouble breathing, stridor, pronounced wheezing, and they get epinephrine, their symptoms then completely go away, I would, my take home from this findings are that you would probably need to watch them, longer than the patient with less severe symptoms. So maybe around, a good 4-hour period would suffice. And then we looked at patients with less severe cardiovascular involvement. So those were patients who just had, like dizziness, more subjective findings, and there were only 156 patients. And then we looked at the patients who had severe respiratory involvement. So that's altered mental status, hypotension, or they actually syncopized, and there were 258 patients. And when you look at those patients with more severe respiratory involvement, their risk of needing a repeat epinephrine really, goes down. At 4 hours, their risk of needing repeat epinephrine after 4 hours is 3.9%, so almost 4%. But beyond 6 hours, it's only 1.9%. So again, I would say, for patients who are really sick with cardiovascular involvement, they, either hypotension that resolves completely, they should be observed for probably at least 6 hours, or at our institution, we would typically hospitalize them if they were really hypotensive. But there is that possibility that they could go home. So in terms of, like there are some limitations of this study. It is, it's obviously a retrospective study, so there's potential for errors in data imputation. We try to address that. We had two raters at each site look at inter-rater reliability visits, which was helpful to make sure that there was agreement. I think there's probably going to be less agreement in what happened before patients arrived in the emergency department, because we're relying on what's documented in the record, but what's reported by patients and their caregivers. But that's always a challenge. But I think using the timing of epinephrine is helpful because it's objectively recorded in the electronic medical record, especially the hospital-based doses. But there's also a lot of, as you are probably well aware, there's a lot of variation in when people administer epinephrine and what indications they use for it, right? That there's We know that around the world and within centers, there's variation in people's threshold for using epinephrine. So while it's a objective marker, it may not be the best marker to say how long we should observe patients. The other thing that I think is important to think about is that we look for, what is your cumulative risk of needing additional epinephrine when patients, go home or so forth. But I think if patients have auto injectors, or now in the U.S. and in many parts of the world, there's intranasal epinephrine that's being approved. That if patients or their caregivers have these epinephrine devices and they go home and they have to use them, they're almost always have good outcomes. That if someone needs another dose of epinephrine and they have to come back to the emergency department, while that's maybe not amazing, the chance that they're going to have a serious life-threatening event after leaving the hospital is very uncommon. So again, that's why I think some clinicians, tolerate a greater than 0% risk of receiving epinephrine after leaving the emergency department. Especially now that there's an emphasis in the US and some other places that once you receive epinephrine in a community setting, if your symptoms abate, they get better, they don't come back, that you don't need to go to the emergency department, especially if you have a backup device. So I think that's where the risk tolerance comes in. And in my practice, what I try to do is, we just changed our anaphylaxis pathway to incorporate these different observation periods where, if you have a less severe reaction, no significant, respiratory cardiovascular, 2 hours is probably fine. If you have, significant respiratory involvement, 4 hours, and then cardiovascular involvement, hypotension, it's at least 6 hours or hospitalization. And then when patients go home, it's just essential to make sure, if your health system can do it, that they, have epinephrine devices on hand in case symptoms return, that they're educated on, when to use epinephrine, and then that if they have the ability to see an allergist to try to identify what their triggers are, see if there's other triggers, and then to try to have long-term health maintenance to talk about different therapies to reduce their risk of having anaphylaxis in the future. So things such as oral immunotherapy is an option for some patients. The use of Xolair is approved in the US for highly allergic patients. And then there's going to be newer therapies, such as a patch therapy to desensitize patients with peanut allergy. So I think there's going to be more and more therapies out there to try to hopefully not cure, but to treat these patients who are food allergic, so that they have a decreased risk of having subsequent anaphylaxis. So seeing an allergist, if possible, is really helpful. But again, at the end of the day, I always say that, this is data to help inform care, but they should never be used to dictate care. That at the end of the day, the clinician treating the patient, has a good sense of how sick someone is, and you have your own tolerance, and then to try to do shared decision making with the patient, their caregiver. I think patients, our caregivers especially, are very comfortable with saying, "Hey, no, I feel good about how my kid looks. I feel comfortable going home." And there are some who say, "You know what, I would feel better being admitted or observed longer." And in those situations, I try to comply with that. And then usually, as they keep being observed, they're like, I'm ready to go home. I'm kind of sick of sitting here in the emergency department." And that's kind of like, I would say, the main gist. We're doing a prospective study now in a couple of emergency departments to try to look at time and a symptom duration to inform observation periods. I think there will be more data to come going forward, but I think this study was a very important first step in trying to inform how we manage these patients. So that's my long-winded summary of the topic.
That's amazing, Dr. Dribin. Actually, you take us through an overview of your article. Was really impressive. We have a question from my side, along with the questions from the audience. One of the questions has been said that it was really an informative presentation. If you can elaborate more on the minimum duration regarding repeat dose of epinephrine.
Yeah, so the point of this article was that it's the last dose of epinephrine, right? So this accounts for patients who get repeat doses. And in our practice, if someone gets a repeat dose of epinephrine, that is not a reason that we admit them to the hospital. If they get 3 or more doses, that's a totally different story. So I think it also accounts for when the repeat dosing is. There are some patients who are a little larger in size who may get 2.3 milligram dose of epinephrine, and those patients, in a way, I almost treat that like an adult dose, right? Because if you get the auto injectors are typically the max dose is usually 0.3 milligrams. Australia has a 0.5 milligram auto injector, but if you get 2.3 milligram auto injector doses, that's 0.6 milligrams, and the max adult dose is 0.5 milligrams. So if it's somebody who's a little larger, or the doses are like back to back, I'm not as worried about that. And then I think it just, if you give 1 dose of epinephrine and then maybe you need to give a second dose and you're a little unsure, like, did they really need it or not? And their symptoms completely get better. Again, I think that's a patient that you could then, if you have capacity in your emergency department, keep observing them. If their recurrent symptoms or their second dose symptoms are a lot worse, and they now have respiratory distress and everything, that may be someone that you decide that, hey, I need to observe them, in the hospital setting. When we look at total number of epinephrine doses in the cohort, 85.8% of the cohort, so again, of that 5,641 received 1 dose, 11.8% received 2 doses, and then only 2.4% received 3 or more doses. So again, it's pretty uncommon, even among those patients who receive 2 doses, to then go on and receive 3 doses. Only 0.8%, ever needed vasopressors as well. And then the rates of biphasic anaphylaxis was just 1.5% in this cohort. 4.2% were biphasic non-anaphylaxis. And then for refractory anaphylaxis, which is those patients who need 3 or more doses of intramuscular epinephrine or started on a vasopressor, that was only 2.1%. So I think in general, my take is that the sickest patients are pretty obvious, early within the first hour. They're quite sick. Those patients, we don't need management guidelines to say how long to observe them for. Those patients need to be usually in the ICU, be hospitalized. But it's those patients who, get better quickly, even if they have more significant findings, those are the ones that I think we could potentially shorten some of their observation periods. The U.S. guidelines in 2020, they basically said there was insufficient data to come out with a definitive time period. The recommendations had looked at some cost effectiveness models of short, like an hour versus extended observation periods, and they said it was not cost effective for extended observation. I would suspect that in the new practice parameter, this article and some other articles they may begin to say, that shorter observation periods are, at least for kids, are feasible. But again, it usually takes a little bit more than one article for them to change that. But this article came out after that. So we'll see what starts happening with the allergy recommendations about observation periods.
Yeah, so going back to the epinephrine, have you documented the epinephrine doses intervals between the first dose to the second dose?
Yeah, so if you look, the table 1 in this it's very long, so there's a
Yeah.
ton of information in there. But the median time between the first and second dose was 82 minutes.
Oh, okay.
Interquartile range was 48 to 135 minutes. And then the median time between the second and the third epinephrine dose was 55 minutes.
Mhm.
Interquartile range what was this, 23 minutes to 136 minutes. But again, that's a wide interquartile range because there weren't many patients
Mhm.
who received 3 doses.
Okay, so your recommendation regarding the repeated doses of epi depends on the clinical status of the patient.
Yeah, yep. I think
Just
it
the average or timing of the patient's
yeah,
first epi.
yeah. Yep,
Oh,
but it's that first epi dose is the one to, but again, if if you have like a biphasic reaction and then all of a sudden, that's 2 hours later that you have to give another dose of epinephrine,
mm,
then I think you just need to, apply your clinical judgment about, do you admit the patient or do you want to watch the patient another, 2 hours? It depends on how significant their other symptoms are and their response to that dose of epinephrine.
amazing, clear. Another question from the audience, Dr. Aruba asking about current guidelines and our practice recommends hospital admission for patients requiring more than one dose of epi. Since your study suggests shorter observation periods, do you think your findings are sufficient to change this practice for patients who required a second dose early but then completely recovered? Or would you still recommend admission for this subgroup?
Yeah, we here, and then I know a lot of U.S. Centers have moved away from two doses as an automatic admission, like I said. So I think for three or more doses, they should be admitted. But if they get two doses and you can observe them and they get better and they have a backup device, I think they can go home so long as, their symptoms were never, significant, respiratory or cardiovascular findings and that the patient has, a backup device. But, for those patients, their symptoms need to almost, they could have a little bit of urticaria maybe, but if they have any ongoing respiratory or cardiovascular symptoms, they should be admitted. I think it's different than asthma where, we'll send kids home with asthma who have some wheezing still. But with anaphylaxis, you should not have any wheezing or ongoing active respiratory symptoms. Like they need to be admitted if they're still symptomatic from a respiratory or cardiovascular, or if they're having ongoing GI symptoms, they need to be, admitted as well.
Okay,
So yes,
perfect.
I definitely think it's a great opportunity to not use two doses of epinephrine as the default. You have to be admitted. And I think a lot of that too is the variation in how people use epinephrine. I see people have a very low threshold for administering epinephrine, where they give it if they just have like the slightest saying their throat's a little tight or they're having trouble, they'll give epinephrine, right, without any objective findings. So I really I would then be very cautious, to just use the number of doses as a de facto thing and to rely on the response of epinephrine and then what were the objective severity of their symptoms.
Okay, perfect. I have a question following the first question. What are the evidence or implementation strategies still needed before shorter observation periods can be safely adopted worldwide?
Well, I think the big thing is just knowing the limitations. So I think for adults, we still don't know how long to observe them. They have more comorbidities, they're on antihypertensive medications that may blunt their response, and may predispose them to having more cardiovascular findings. So I think this cannot be used for adults. However, it always gets back to like when should we implement something and when should we change practice? I think the data from this study is by far the most robust data ever generated to figure out how long to observe patients. So my belief is it's always better to use the best data that's out there than prior recommendations that were based on almost no data.
Mm-hmm.
People, I think, have a tendency to rely on what we've done in the past
Yeah.
because that's kind of like standard of care, even with when we've done in the past was based on almost no data. So my belief is that these data should be what should be used to inform pediatric anaphylaxis care uh, going forward, recognizing that there's still new data that needs to be produced, prospectively in other countries to look at, there may be differences in, allergens across the world. There's very few insect or venom-induced anaphylaxis in this cohort. So, it's probably not great to, capture that. But I still think it's better to use the best data that's out there to inform care, knowing that there's still need for more data to continue to answer this question. And as more data is generated and we have a better sense of things, I think we then will continue to modify recommendations. That I don't see this as the door is closed or this is the definitive answer. I see it as an evolving journey that we as researchers and then us as clinicians always need to adopt our practice based on the next studies that are out there. So hopefully, yes, we have a definitive, large, big prospective study to definitively answer that question. But until that happens, I do think it makes sense to use the best available data that's out there while recognizing that that data should help inform but not dictate your clinical practice.
Yeah, I cannot agree more, actually. So we need to follow the standard of care till it's proven otherwise. We need more researchers to at least give us an agreement about the new shorter period of observation to be covered worldwide instead of giving them a lengthy periods. In my experience, to be honest, I actually followed what you have done in your research article in my ED setting in Riyadh. And I actually have observed that 2 hours is a better period observation, and it's sufficient in comparison to 4 to 6 hours as a standard of care. But again, I cannot say and I implement this worldwide to be followed. It depends on person, ED settings, and the standard of care by the Allergy Immunology Association guidelines. Another
And I,
more.
and I would say that for ED doctors, like I think it's always I'm a big believer in standardization work. So here at Cincinnati Children's, we have our guidelines that are then published online. Children's Hospital of Philadelphia does a really good job of that as well, publishing pathways. I think it's really good for emergency department centers to have their standardized approach to how clinicians manage patients, so that people try to adhere to the same thing, so there's not that variation in care. I think it also just makes it easier that, for nursing and everyone else to say, hey, we're all trying to approach this in a not manage it exactly the same, because we know that's never going to happen, right? But we should try to have a similar approach, and I think a really good steps for people is to say, hey, I think the first thing is to say, we don't need to hospitalize every patient who gets 2 doses of epinephrine, right? If someone gets a dose before they come in and then you give a dose, I think that's a really good area of improvement to say those are patients we could potentially reduce. And then for those really non-sick patients who never had, respiratory cardiovascular, I do think a 2-hour period is totally safe. And a lot of the allergy centers in the US, they definitely don't follow people for 4 hours. They do a lot of oral challenges, and most of them have been doing 2 hours for a long time. So I think emergency departments inherently are just more conservative, which makes sense, right? But I think 2 hours for a lot of people is something that people can start to work for or work towards. And just to observe it in your own practice, I think most of us would say, hey, yeah, like it's pretty uncommon that I've ever had someone who has recurrent symptoms 3-4 hours later after being asymptomatic, right? Like I think we know the patients in front of us, and we have our clinical gestalt is probably pretty accurate as well.
Yeah, you're right. Actually, cannot agree more. We have another question. Cardiovascular involvement emerged as the key factor associated with lung risk of requiring repeat epi. How should this finding change our current risk stratification and disposition decision in our EDs?
Yeah, I think one of the reasons that we looked at observation periods is that the decision around who is admitted and who's not admitted is often based on hospital factors. So there are some centers that have the capacity to observe patients for a long time in emergency departments, where they have observation units, right? And they could observe someone for 12 hours, right? There are other healthcare centers where their emergency departments are so busy that they don't have capacity for that they need to admit patients quicker in the course, right? So that's why that's why we looked at observation times, is that people, irrespective of their system level factors, can then decide, if I have an observation unit and I have that patient who was hypotensive, but then their symptoms completely resolve, that patient I could keep in my emergency department and watch for at least 6 hours. And if their symptoms don't come back, I could send them home. Versus, oh, I need to admit the patient because I don't have capacity. That inpatient doctor can say, okay, I'm going to watch the patient maybe 6-8 hours, but they don't need to stay 24 hours if their symptoms completely resolve. But I think one of the clearest risk factors for biphasic reactions and everything has always been hypotension. That's like, there's all these like different stuff that's been tried to use to identify biphasic reactions. Really, I think it's really hard to predict biphasic reactions. And I think the risk of biphasic reaction is very low. It's uncommon, and I don't think that risk should drive clinical care a ton, because again, it's uncommon, and significant ones are uncommon. But if someone's hypotensive, or you have a baby who has, they're sitting there and they look good and they have pronounced tachycardia, that's probably cardiovascular involvement. I do think, those patients definitely need to be observed longer. And I think 6 hours, at least 6 hours, or admission, if their symptoms, go away, is makes sense. Now, if they have ongoing hypotension, I think we all know what to do with those patients, that they need to be in an ICU setting. But even for those sick patients, the hypotensive patients, it's pretty darn rare to need to be on vasopressors for more than 6 to 8 hours. Usually even if you do really good fluid resuscitation, they're going to get better. And I would say that's one thing that, to stress. We always say epinephrine is the first line therapy, and it definitely is. We have a new paper that's going to be coming out to say, how do you manage these patients with refractory anaphylaxis? And this is incorporating intranasal epinephrine. And one of the big things, just to reemphasize, is that, you have to give epinephrine, and repeat epinephrine, and, start the epinephrine infusion early in the course for those sick patients, but you also have to aggressively fluid resuscitate these patients. So I think for those hypotensive patients, really make sure that even if their symptoms get better, to fluid resuscitate them, that can be a key thing for patients with cardiovascular involvement. So always remember the importance of fluids. We rarely put IVs in these patients, and the mild kids, they always used to get IVs and steroids, and we've really moved away from that. That if their symptoms totally get better with that one dose and they're looking good, we avoid it. But for patients who have, true respiratory distress, true cardiovascular involvement, they need, intravascular access, fluids, and other cardiopulmonary support.
That's amazing. Since you have bringing the intranasal epinephrine, how efficient is the intranasal epinephrine treating anaphylaxis in comparison to the IM, since we know it's the standard of care?
Yeah, so I would say, intramuscular has been considered, it was the only route that was available. So it was the standard of care. I would say right now, we can't say intramuscular is the first line therapy. I think we have to say epinephrine is, and that's either intramuscular or nasal. And the reason I say that is when, the FDA or the European Medicines Agency or Health Canada approves intranasal epinephrine, they're treating them as equivalent. Like, they're saying, we think it is sufficient or non-inferior to intramuscular. So I think we as clinicians have to treat them as it works, and it should work awfully well. Kind of how I would say we manage status epilepticus, right? We don't say that, we look at intranasal, midazolam versus intramuscular route or intravenous, for benzos as we count those as, a benzo dose, irrespective of the route of administration. That being said, there's never been a randomized controlled trial of anything in anaphylaxis, or a large definitive one. So even intramuscular epinephrine, there's never been an RCT of it. The epinephrine was approved based on pharmacokinetic and pharmacodynamic data. So different formulations of autoinjectors, such as we have what's called AviQ. I don't know if you have it in Saudi Arabia, but it's the device that talks to people and tells them how to use it. Those devices, all the regulatory bodies basically said you need to show that it has similar parameters, PK, PD parameters, as the other intramuscular epinephrine. And that then is how the nasal route was approved. They did it in healthy subjects. They did look at it with some patients who had allergic rhinitis to make sure that the nasal congestion didn't impact stuff. So I think at this time, we don't know the answer, right? The intranasal route could actually be better than the intramuscular route. It could be equivalent, it could be non-inferior, or it could be inferior. But until we have that data, until there's an RCT looking at that, we don't know. So I think the way that I view it in my practice is I still think, we need to treat them as the same. But I think one of the things that this new paper that will be coming out shortly is saying is that we don't want clinicians for a patient, we don't want somebody who receives 2 doses of intranasal epinephrine and they come into your center and they still have anaphylaxis. We don't want you to then say, all right, I now need to give another 2 or 3 doses of intramuscular epinephrine before I think about starting an infusion. That you should count the total number of epinephrine doses irrespective of route when deciding whether to start an infusion. We're worried that people could assume the intranasal route will be less effective, and that could then result in people getting multiple doses of IM and maybe getting 5 or 6 total doses of either intranasal or IM before starting the infusion. So I think at this time, until we have better data, I would recommend treating them as the same, and then going from there. It's also hard for our patients going home. Like there are some people who are fine with the intranasal route, that they're like, I think it's fine. There's some people who would say, hey, I'd rather have the intramuscular route. It's worked for me. I know it. And I think that's fine. I think it needs to be based on patient preference. And then my last thing I would say is that there's some people who don't use the intramuscular route. They don't use their auto injectors. They have needle phobia. Some teenagers don't want to carry their devices. So my belief is I'd rather have someone have a device that they're going to use than have a device that they won't use. I think using it is always going to, even if the intranasal route is maybe a little less effective, let's say, which I don't know if it is, I'd rather have that person use it, the intranasal route, than have their auto injector and not use it, right? We know that delaying epinephrine administration, is or underuse is definitely a risk factor for adverse outcomes. So I think there will be more data to come, hopefully, to try to answer this question. I think observational data alone is going to be totally insufficient to answer this question, because my worry is that I think people will have a lower threshold to use the intranasal route, right? That they may give intranasal for mild symptoms, right? And then they're going to say, oh, they did great. They only needed 1 dose of intranasal. Whereas if you have someone use intramuscular, I think they're going to have a higher threshold of when to use it, where maybe they're going to say, oh, I need you to actually have anaphylaxis before I administer IM. So I think the severity of when people, the severity threshold of when people use the different routes, I imagine will be different, which I think will make it very hard to compare, efficacy when you look at these outcomes.
Amazing, sufficient. Last question before we conclude. If you were revising international pediatric anaphylaxis guidelines today, what specific recommendations would you change based on the findings of the study, and what areas would still require further research?
I think the areas of further research I mentioned, I think we need to look at adult patients is one important thing that we still don't know. And then other areas of research, I think, are prospective data to look at not just the timing of epinephrine, but objectively looking at when their symptoms resolve, or they only have mild symptoms, would be an important way to try to answer this question. But I do think guidelines, I think the time thresholds that we've identified make sense. I don't like having weird 1.3 hour observation periods. I think it needs to be easier for people to remember. So I do think 2 hours, 4, 6 is a nice, easier to remember kind of thing. So I do think saying that for patients without significant respiratory involvement, 2 hours is fine. For patients with more significant respiratory involvement that completely goes away, 4 hours is fine. And then for significant cardiovascular involvement that completely goes away, 6 hours is good. And then this is nothing new, but just making sure that patients always are prescribed some epinephrine device when they leave the emergency department, ideally in hand, that they need to see an allergist. That stuff is not changing going forward. So that would be kind of my thoughts. But I always worry with these recommendations that people just err on the side of, oh, I only need to watch someone for 2 hours, right? And that's not the case. I think we need to make sure we recognize and stratify our management based on how sick people are. And I think clinicians have a good gestalt of our patients sicker than they think, and they should be encouraged to observe for longer or hospitalized based on that.
Yeah, I cannot agree more. Lastly, any last comments from your side, Dr. Dribin, before we conclude?
No, not really. Thank you for inviting me, and please reach out if you have any other questions. It's been a pleasure talking with you, and I really enjoy the questions, and happy to take any other questions if you have them.
Any questions from the audience other than we discussed earlier? I don't think that we have anything in the chat, to be honest, or I receive it personally. Thank you so much, Dr. Dribin, for your insightful presentation and discussion. And I would like to thank everyone who joined us in this engaging session. And we appreciate your participation and support. And let's see you all in our PediEM Journal Club 13, inshallah, next week. Thank you so much, Dr. Dribin.
Thank you, and thanks for what you do for patients. Appreciate
Thank
it.
you so much. Appreciate you too. Thank you.